Hello everyone, this is Dr. Omar Shakuri and today we will continue our free AMC MCQ booster course with Soma. We will continue to the lecture 3. I'm a senior house officer, accident and emergency surgeon. I will be your tutor for this lecture. Just to inform you that I will put down the Facebook group link. You can join us for more and more MCQ to be solved together. Also, you can subscribe to our website somastudy.teachable.com. You will find some free courses. What's available in Soma Study? This course, also the free booster course, is also available in somastudyteachable.com. I will put the link below and you can get the PDF file to print it and to put your notes over it during watching this class. Thank you for being one of my students. Let's go to see the lecture 3 of this course.
So what is the cause of this seizure? Adrenal failure will not be accepted. Dehydration is not accepted. He's on treatment. The only accepted one is also SIADA because of the hyponatremia. Hyponatremia will cause this seizure, and mentioned in the scenario the only labs we're giving with sodium and bicarbonate are low. So it's hyponatremia. Hyponatremia caused, the most common cause for hyponatremia is SIADA, and SIADA will cause epilepsy, epileptic attack. Keep it in mind. Hyponatremia equal SIADA equal convulsion. Not dehydration, Dr. Muhammad, Dr. Mariam, it's not dehydration, it's 1 day after admission. So the patient rehydrated well in the hospital. The only acceptable one is the low sodium, and this is hyponatremia caused by SIADA, and SIADA cause the convulsion. Okay. Waldenstrom macroglobulinemia patient came with rigor and fever and right lower pneumonia or some infection like this, admitted and started ampicillin. After minimal time, generalized vesicular rash appeared, asking about management. What do you think? What do you think the cause of this generalized vesicular rash? Yes. The most acceptable drug or management to be given for this patient is antiviral. This is a viral infection caused generalized vesicular rash because of low immunity of the patient. It's not because of the drug allergy. It's generalized rash. Whenever you see generalized vesicular rash, it's mostly caused by viral infection. So look in the scenario of your patient is immunocompromised. Yes, if drug allergy, the rash is erythematous, not vesicular. Yes. Whenever, as I said, whenever you have seen generalized vesicular rash, think about viral infection. Generalized vesicular rash, think about viral infection. Question number 25. A patient has pneumonia. His hip muscles become weak. CT show spiral stenosis. He is on statin, on multiple drugs. On examination, knee jerk is absent. Lower limb power is low. Absent dorsalis pedis. Pulses and sensation over thigh is lost. What's the next investigation? Is it to do MRI for this patient? Is it to do X-ray? Is it to do arterial duplex? Is it to do creatinine kinase or lumbar puncture? Why it's A? Why? Okay, it's A. I will accept that. It's A. It's we have to do MRI for the patient, but why? No duplex. It's to do MRI for the patient because our patient not only less of whenever you have see a combination of sensory and motor affection, whenever you have seen a sensory and motor affection, directly go to the examination of the root. And how we can examine the root of the nerves? We can examine them by MRI. As simple as that. So sensory and motor affection equal MRI. Okay. A child presented with 3 days history of fever, cough, and he was grunting. His temperature was 39. Chest examination relieved left basal dullness and trachea shifted to the right. What's the antibiotic of choice? What do you think? What's the case scenario? What's the diagnosis for this child? Absolutely, I will accept that. It's pneumonia. And what you will choose? Pneumonia with the pleural effusion. I will accept it with the pleural effusion. Okay. The IV fluoxacillin, IV. I want you to know, believe me, if this scenario come to you and you did the answer by IV penicillin or IV fluoxacillin, you all will fail in this MCQ. Regarding the treatment of pneumonia in children, according to the Australian clinical or Australian Royal College of Pediatric, the first drug to be given is oral, not IV. We can use IV if there is vomiting in the scenario. If the same scenario and the child, in the scenario, you will see many scenarios with that. In the scenario, there is vomiting. So even if it is mild pneumonia or severe pneumonia, you will go directly to choose IV antibiotic. But in this scenario, it is not severe. It is a mild case, and there is no need to give IV antibiotic directly. We have to choose amoxicillin. As simple as that. Not IV medication. Even it's grunting. Grunting does not reveal the severity of pneumonia. The severity of pneumonia, the patient will got tachypnea, will got tachycardia, use of accessory muscle, respiratory distress symptoms. And here there is no respiratory distress symptoms. The patient come with history of 3 days, fever, cough, and grunting, not acute attack. Okay? So this is a typical scenario for the pneumonia, and they want to know that you are oriented on how to give IV fluid in pneumonia or not. Even if fever, yes, it's pneumonia, Dr. Mariam, it's pneumonia. So the patient got fever. It's accepted. Not severe. There is no respiratory distress. Okay. So the first drug in pediatric in a case of pneumonia is the amoxicillin. And if the same scenario, this is a mild pneumonia, if the same scenario, but said in the scenario, there is vomiting, the child vomits twice or one time, so this will be the indication to give IV antibiotic, which is IV penicillin. Okay. I will go to the next. A child presented with cough and wheeze and intercostal recession and accessory muscle use. Okay. He has fever 39. On examination, chest was clear. He is treated with IV fluid and oxygen. Which organism is responsible for this condition? Okay, what's the condition? What's the diagnosis? Dr. Lara. It is not a croup. It's a bronchiolitis. Not a bronchitis, it's a bronchiolitis. Good, good. This is a typical case of acute bronchiolitis. So this is also one of the common questions in the MCQ. What is the most common organism for bronchiolitis? It's RSV, respiratory syncytial virus. This is because of the recolor. There is a wheeze as a presentation, but on examination of the bronchiolitis, you will hear nothing most probably in your exam. Not mentioned by the recolor. In your exam, it will be mentioned, not to tell you just a child presented. They will tell you, and the peak incidence for the bronchiolitis is from two months to 2 years, and the maximum is on 6 to 9 months of bronchiolitis. Yes. We are here solving, let's say, not incomplete, but this is not the full scenario as the exam. I am learning you how to pick the most important keywords in any MCQ. So in your exam, you will face any MCQ and you will know how to pick it out and to solve your MCQ on this scenario. Don't depend on books, just depend on the Australian Royal College of General Practitioner, how to deal with the cases, and the Pediatric Royal RCH. And just I want you to write down what I am saying. I'm giving to you the tricks about that. Okay. ECG of 60-year-old man show arterial flutter on 4 to 1 with hypertension, diabetes. Patient has no complaint of dyspnea. What's the management? What's your management for this patient? It's not mentioned there, right? Dr. Clear, I think you attend the ECG notes, so you know it. Yes, it's added warfarin. Why not? Well, okay, I want Dr. Clear to answer this. Dr. Claire?
Because
Yes.
it didn't mention anything about the rate. So I assume the rate is normal. Patient has no symptom, no complaint of dyspnea. So we don't need to give any rate controlling medications like beta blockers. We just add warfarin.
Yes, thank you so much.
Welcome.
Okay, in the treatment of atrial fibrillation and atrial flutter, we have two lines for the treatment, either to give a rate control medication or to add warfarin. In this scenario, there is no any word about that the patient got irregular pulse. So we will not give the metoprolol, absolutely, and we will go to added warfarin only. So I will repeat again. In any case of atrial fibrillation or atrial flutter, they both have the same treatment. The treatment consists of two lines, either to give a rate control medication or to give to added warfarin. We are speaking on stable patient, not unstable. Unstable has another rule. Unstable patient will be treated by synchronized defibrillator, synchronized cardioversion. But in stable patient like this, we will give a rate control medication or added warfarin. It's very common scenario. It's very important scenario. If lower, even if it is 2 to 1, and the same scenario, and the rate is stable and the rate is controlled, you will give warfarin. One. For this, you will give just warfarin. In your scenario, it will be like this, as simple as that. Okay. 17-year-old boy presented with the old boy says he has to count till 20. Dr. Shan, in this question, I will go back. I want you to keep it in your papers. According to the AF, or atrial fibrillation, atrial flutter, we have two types of them. Either your patient is hemodynamically stable or unstable. If the patient was unstable, we go for the synchronized cardioversion. This scenario is rarely come in the exam. The most common scenario is came with that patient with AF and the patient is stable. So you have to look if there is controlled rate, the rate is not elevated, there is no tachycardia, so directly to choose added warfarin. Why added warfarin? Is to prevent the strokes or thrombosis in the future. If the rate was not controlled, you can choose a rate control medication. Okay, as simple as that. AF equal either rate control medication or added warfarin. And now you know how to do it. Okay. 17-year-old boy says he has to count till 20. Otherwise, her mom will be, of course, this is boy and her is not associated with each other. So let's say a girl, so it will be better. Wise her mom will be killed. They has a minor accident 3 months ago. Boy is keeping himself into the room. most of the time saying he's hearing the voices but couldn't recognize it. What's the diagnosis? Is it OCD, severe depression, schizophreniform disorder? What do you think? See, yes, most of you, yes, yes. Why we are, if there is another choice, like, is it schizophrenia? Let's say here, schizophrenia. Schizo. Why it's not schizophrenia? That's what I want you to know. Because of time factor. Yes, what's the time? Yes, Dr. Vin. What's the time factor for it, for diagnosing of schizophrenia? 6 months. That's good. You are oriented. Okay. Okay. Good. 3 months, the boy start to be on schizophrenia road. So I call it schizophrenia road. It's schizophreniform. Schizophrenia road. Schizophreniform. Those who are using their mobiles, their phones. Is it clear? Dr. Muhammad, put your question in public to everyone can see it. Dr. Muhammad asking about what's the key here for diagnosing the schizophrenia type. The schizophrenia, you can, yes, you can see it. We have two keys for diagnosing the schizophrenia or the schizophrenic person. The first key is that your patient will be young, and this patient is 17-year-old and he has withdrawal manifestation. Withdrawal manifestation, as simple as that, means the your patient will be go away from the school and go away from the social and take a part in home and not speaking to anyone. These are the key to how to diagnose the schizophrenia. So if your patient is young and got withdrawal manifestation, that's mean your patient is starting to go further in schizophrenia. So according to the time, if he got this manifestation for more than 6 months, it's schizophrenia. If less than 6 months, you will go for schizophreniform or schizophrenia road. Does it clear now? Okay. A young adult, question number 30, a young adult male who is excellent health come with palpitation after 15 kilometers of running, 5 stripe of ECG and no SVT is giving. What's the most common cause of this palpitation? What do you think? In young adult, got palpitation after 15 kilometers of running. What's your provisional diagnosis and why this palpitation happened? He is young, he is healthy, wealthy, but got this palpitation. The answer, yes. Yes, absolutely. It's HOCM. So it is VTAC or VF. It's most probably VTAC in this patient. What's the HOCM? Hypertrophic cardiomyopathy. This is very common and very important scenario. The HOCM is very important topic. You have to know it in your exam. It's the key for diagnosing HOCM is that patient is young patient with the history of palpitation after sports exercise. This is directly will guide you to the diagnosis of HOCM. One of the tricks in HOCM is what's the associated most common types of arrhythmia. These are VF and VT. Here in your choices, there's only VT will be accepted for this MCQ. So I will repeat again. Whenever you see a young patient plus palpitation after sport and exercise, you have to think that the history is about HOCM, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is very common in young adults, and the other key will be positive family history. In the full scenario, you will see that the father is died in young age also. And now your patient is present by palpitation. You have to think that this is occurred by the association of the HOCM, VT, or VF. Dr. Lara, the question is not about is stable and what's the treatment or not. Here the question is just about what is your explanation for this palpitation. So as I mentioned, young with palpitation after exercise, directly think about the HOCM. When you think about the HOCM, directly think about the association VF and VTAC. VF will kill the patient young, and VTAC will cause the palpitation. Sometimes the same scenario, but they will say the young patient is suddenly dead after sports. So what's the diagnosis? The diagnosis is HOCM. And what is the cause of this death? The cause of this death is the VF, acute VF, which is associated with the HOCM. Yes. Good. Now patient was brought to the emergency room after a fight causing a stab wound with a knife in the chest. Patient blood pressure was normal. Okay, but his oxygen saturation is mildly decreased. He is calm. He only has a mild dyspnea, and on examination has dullness on percussion, decreased air entry on the left side, and the trachea deviated to the side of the injury, not the opposite side. Sorry. So what you will do? Is it to give oxygen? Is it to put chest tube? Is it to do thoracocentesis? Is it to give IV fluid? Just cover the wound and send him home. Yes. Let's reveal our information here. Blood pressure was normal. Patient has mild dyspnea. Oxygen saturation was decreased and he is calm. So the patient is a little bit, let's say it's a stable patient, but he is dyspneic, and there is dullness on percussion and decreased air entry on the left side with the trachea deviation. What does this information relieve for you? It's a stab wound in the chest. So we have to think that we have with chest symptoms. So we have to think that there is pneumothorax or hemothorax. As simple as that, hemothorax will bring the trachea toward the side of the injury, hemothorax toward the site of the injury, and pneumothorax will deviate the trachea toward the opposite side. When the scenario is like this, trachea deviated to the same side of the injury, so we have to think that there is a hemothorax. Hemothorax, the next the next step to be done in massive hemothorax that make chest compromisation like this is to put the chest tube. So here the B answer, the chest tube, will be the correct answer. The oxygen is to give oxygen will be the correct answer if it's mentioned the oxygen saturation is severely decreased or is 70, for example. So the next step will be oxygen. But here your patient is calm and oxygen saturation is mildly decreased. So it's a scenario of massive hemothorax in the chest, pulling the trachea toward the site of injury. So we have to put chest tube and evacuate the blood from the chest. I'm sorry. Not mentioned in the scenario of anything about the ABC. It's just mentioned what you should do. According to the scenario and to the options, you will respond. So in this, they told you that as simple as that, they do the blood pressure, so they check the circulation, which was normal. They do everything, and oxygen saturation was mildly decreased, and they do the breathing examination. Now, what's your intervention as a doctor? My intervention is to put a chest tube. Okay, Dr. Lara? Yes, Dr. Muhammad. If the same scenario, but there is oxygen saturation is very low, the next step will be O2. Dr. Lara, it's a case, please. Think like AMC who put the question. When the examiner said that O2 saturation is mildly decreased and the patient is calm, what's your next step? My next step to discover why this dyspnea and this dullness and this shifting of the trachea happened and to treat it. So here I will treat the hemothorax by putting a chest tube. If the patient if in real time, in real hospital, okay, not in exam, if my patient got this feature, I will put the chest tube, and I will put the patient on monitor of pulse oximeter, so I can keep following with others' needs. But for the scenario, for this, they want you to know that whenever there is a massive hemothorax, you have to put the chest tube. It's mandatory. Okay? Okay. Patient with BMI 35, what is the best management for long-term weight maintenance together with exercise? This scenario is not coming like this. It's just come for one time and not repeated in other months. But what do you think is the answer? Yes, it's lipase inhibitor. Exercise plus lipase inhibitor. Yes, yes. It's one of the rare questions. I want to say that the unknown questions or rare questions or medication questions, drugs questions, these are come about, let's say, less than 7 or less than 10 in your exam. And about 5 of them will be unscored question. So whenever you seen in your exam a question about a drug side effect or non-drugs combination, is it appropriate or not? This most probably will be non-scored question. So put any answer if you don't have any idea about this question. Put any answer and go for the next. Don't lose 1 minute on this question. These questions of the drugs, which is unknown drugs, a new drugs, a new generation, you never have an idea about it. It's not a common drugs. This most probably will be non-scored questions just to test ability of the student to choose the appropriate one for it. So directly choose any answer and go for the other. Don't waste your time on this. The 1 minute for this question will help you in another question that you know it and you know the scenario and just you need to focus on what's needed from the MCQ after it. Okay, 17-year-old boy says he has to count also is the same scenario. Boy is keeping himself into the room most of the night. It's the same scenario. Yes, it's schizophreniform disorder. This is common scenario, believe me. And it's repeated in the same month. And in the next month also repeated. Now we will see many repeated question. Sorry. Old women, 75 years old of age, is admitted to the hospital following a community-acquired pneumonia. Okay, we have a case of community-acquired pneumonia. She has received antibiotic and is well on the fifth, and she is well, but on the 5th days, she suddenly developed rigor, chills, high-grade fever on the 4th day. What's the most likely explanation? So you have patient with pneumonia admitted to the hospital. After the admission, she became well, but after 5 days, she got a rigor, fever, chills. So what's the most explanation for that? Absolutely. All of you choose the hospital-acquired pneumonia. Yes, 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 yes. It's absolutely, no, it's not B. It's not bacteremia. Bacteremia will not cause chills, will not cause rigor. IV cannula is not like this. This is a hospital-acquired pneumonia. So This is a hospital-acquired pneumonia. After hospital admission, any patient could get hospital-acquired pneumonia after the third day of admission. Okay, already on treatment, on antibiotic, and became well. She became well, but after that, she got another infection, caused rigor and fever, caused the same feature of pneumonia, and she is in the hospital. Of course, it will be a hospital-acquired pneumonia. She got another pathogens, which is in the hospital available, and making her pneumonia again. This is hospital-acquired pneumonia. Empyema is a grade with anterolateral chest pain on coughing and inspiration, diminished breath sound on the left side, basal crackles on the left, and temperature was elevated. What's the possible diagnosis? What do you think? B. Dr. Naomi, why you choose A? Is pulmonary embolism? Why pulmonary embolism? This is a feature of pneumonia. Everyone can see it as simple as that. She got pneumonia in her travel. This is fever and basal chest crepitation. Yes, fever with basal chest crepitation is pneumonia. They want to make more to take your attention about the traveling, and she has been traveling from UK. Okay, why this mentioned? Pulmonary embolism, you don't have fever in your scenario. Yes. I will jump to another question. A patient has pneumonia. The pneumonia is so important topic. In every question, you got a trick about something in pneumonia. You don't need to read the whole scenarios of the trauma, of the pneumonia, and to read all the topic. You have to focus on what AMC need from you to know about the pneumonia. So, question number 36. A patient has pneumonia. His hip muscle became weak. CT shows, but it's the same question. It's about to choose MRI. Yes, because of upper and lower sensory and motor affection. Sensory and motor nerve affection. Okay, I will jump to other. 4-year-old child presented with cough, wheeze, and intercostal recession. He uses his accessory muscle while breathing. He is feverish and the chest was clear. This is 4 year, not 2 year. And what is the organism responsible for his condition? It's still the same feature. These are the features of bronchiolitis. So you don't, please, don't fix your mind that every case of bronchiolitis should be less than 2 years. This is also a scenario of bronchiolitis. So here is the answer will be the same RS virus, respiratory syncytial virus. Could be. It could be a recaller mistake, but for you, please don't fix your mind on the age. If you got the feature of bronchiolitis and he's still child, okay, it could be. But the most common is up to 2 years. Okay. As 57-year-old male presented with also the same scenario. No, not the same. Presented with Waldenstone microglobinemia and myelodysplastic syndrome, developed pneumonia, penicillin giving. After 2 days, he developed vesicular rash. What would lead you to the diagnosis? Wow. It's the same scenario, but asking about the diagnosis. Yes, Dr. Priyanka, you are absolutely correct, but why you choose skin biopsy? Why skin biopsy? We are still on the same boat. It's viral infection, and viral infection, does the blood culture will relieve viral infection? No. Does the bone marrow biopsy will relieve it? No. Immunofluorescence of the lesion? Why? No. The only acceptable one is the skin biopsy to deal with the virus. Okay, clear everyone? Diagnosis is the same as we mentioned before. It's viral infection. Any vesicular rash, generalized vesicular rash, is a viral infection. Okay. Okay. Question number 39 is a prime gravida gave birth at term to 3 kilo, let's say 3 kilogram, baby normal vaginal delivery without any complication, and there was slight meconium staining of liquor. Baby was normal at birth with normal heart rate. After 1 minute, suddenly the baby dropped breathing, heart rate decreased, cyanosed, no response on stimulation. What's the most appropriate next step? What's the next step for a newly born baby, for a neonate that he is deteriorating? Is it to intubate the baby? Is it to nasopharyngeal aspiration of meconium? Is it to bag and mask ventilation? Yes, you have to know it. It's C, absolutely correct. You have to know that even if there is meconium staining in baby, you have to choose the next step. The best next step is the bag and mask ventilation. You are oriented with that. Okay. Now, baby born with the hepatitis C virus, positive mother, how will you check hepatitis status in this baby? Is it to do hepatitis C virus antibody at 18 months or of age, or at 12 months of age, or at birth? Yes, it's 18. According to Australian Pediatric Society, it is 18 months. You have to check the baby at 18 months of age. And for those who did the MRCP exam, it's 12. According to MRCP, it's 12, but according to Australia, it's 18. Okay? So we are now taking AMC, so it's 18. Okay. Newborn baby born to a diabetic mother at 36 weeks, weight 4 kilo, Apgar was 7, found to be cyanosed on his hands and feet, acral cyanosis, okay? Also, jittery axillary temperature was 37. He improved after aspiration and 100% O2. The most likely diagnosis is, what's the most likely diagnosis for newly born baby with acral cyanosis? If the patient after birth, please write down after birth, if the patient uh, was having acral cyanosis that is improved after aspiration and auto saturation and auto administration, this is of course hypoxia. Hypoxia will cause this. It is not a heart disease, it's not a lung disease. Those will cause head and lip cyanosis, not acral cyanosis. Hypoxia will cause acral cyanosis, and that's why when they give 100% O2, the patient, the child, or the unit got better of this. Okay. A 24-year-old guy, perfectly healthy, heart experiences palpitation after 15 miles of running. Also the same scenario. Who can tell me the explanation for this tachycardia? Young with palpitation. It's VTAC. VTAC due to what? VTAC due to hookam. Good. Good. Okay. Question number, I didn't put it. Man with AF on ramipril, metoprolol, digoxin, went on a trip for 2 weeks and stopped his medication. Now with bilateral edema, now present with bilateral edema up to the knee in the leg and ankle swelling, lungs is clear, lungs are clear, and the patient is not dyspneic. What is the most appropriate management? What do you think? Is it to give furosemide? Is it to give recommends all his medication? Ramipril, digoxin. Yes, yes, yes. Read the scenario again. And absolutely it is to give Lasix, diuretics, furosemide. Bilateral edema and everything is clear. What's the most appropriate one is to give diuretics. Why not B? Recommends all his medication, went and trips and stopped his medication. Even stopping the medication will not cause this bilateral edema. It is just 2 weeks of stopping the medication. He has, in his medication, he has no diuretics. It's just rate control drugs and anti hypertensive drugs. Okay, so what will explain how to deal with this edema? It is just we can deal it even if we let's say if we recommence his medication like ramipril, metoprolol, digoxin. This will not relieve the edema of this patient, so we have to give the diuretics. Okay. Yes, Dr. Lara, you have raised, Dr. Lara, you have raised your hand. What's up? You can speak, Dr. Lara. Okay, I will lower it. Okay. Alcoholic patient present with ascites, gynecomastia, spider nevi, parotid gland enlargement, and flapping tremor, and fever confusion. Vital sign, vitals giving. What's the investigation to do? What do you think? Why you choose E? Abdominal paracentesis. Why? Yes. Yes. Any case with ascites, fever, confusion, these are the trick to reach the diagnosis of liver failure and hepatic encephalopathy, and this is need urgent abdominal paracentesis to confirm the diagnosis. Yes, absolutely, all of you are right. You are oriented about this scenario. That's good. Just keep it in your note. Ascites associated with fever and confusion. This is a scenario of liver failure, a scenario of hepatic encephalopathy, and the investigation that the patient need because of this ascites is the abdominal paracentesis. Okay. Baby 6 weeks of age, persistent vomiting, non-bilious since 2 weeks, and constipation. Abdominal examination cannot be done perfect as the baby was crying, but seems normal. What to do? Is it to do added food thickener or to do ultrasound of the abdomen? Why it's ultrasound? Yes. Why it is ultrasound? What's the provisional diagnosis for this case? It's very important scenario. What's your provisional diagnosis for this case? Not mention that this baby is Down syndrome. Yes, yes, I want you to think like that. These are a feature of intestinal obstruction. These are a feature of intestinal obstruction. In pediatric age group, the only acceptable diagnosis to be presented in early life of pediatric baby, neonate baby, is the hypertrophic, is the hypertrophic pyloric stenosis, not Hirschsprung. Hirschsprung got another scenario. You will see it in next few lectures. The scenario here is about pyloric stenosis cause early non-bilious early intestinal obstruction in the baby. And this could be diagnosed yes. This could be diagnosed by ultrasound of the abdomen. They see the thickening of the sonorist will see the thickening of the pylorus. I want you to keep it in mind. Intestinal obstruction in pediatric with non-bilious vomiting. This is caused by pyloric stenosis.